So how I kind of think of stroke prevention is like, what are the things that we can control? So things, we being patients, family members, doctors, and other healthcare providers. And I know at GF Strong, where I work, this is a question I get a lot. So people feel a loss of control after they've had a stroke, and they're quite scared about having another stroke. And so part of my job when I see patients who've had a stroke is to educate them and their family and friends on the things that we can do as a team to reduce this risk and to sort of take back a little bit of that sense of control. And so in order to kind of address this question, how do we prevent a stroke, we need to look at risk factors for stroke. So what makes one person more likely to have a stroke than another person? And so we break this down often into things we can and things we can't control. And there are a small number of risk factors that we can't really control. And in medicine, we call these non-modifiable risk factors. So these are things like age. So generally, as people get older, they're at a higher risk of having a stroke. Gender. So at younger ages, men are more likely to have strokes, but actually overall, we're seeing that women tend to have more strokes, especially as they live longer. Certain ethnicities and races have higher risks. Looking at your genetics or family history. So some people may have a family member, like a parent or sibling, who's had a stroke. And then finally, having had a stroke or mini stroke, TIA, can also increase your risk. So these are the things we can't really control. So we're going to kind of push those aside and look at the things we can control. The good thing is this list is way longer, the things we can control. So I'm going to go through most of these. No need to try and frantically read them all. But these are the things that we call modifiable risk factors. And these are the things that your doctors and nurses and things will be testing you for and providing guidance on what you can do about them. And I like this picture because it sort of shows how many more modifiable factors there are. But I also like to point out that all of these things in the modifiable, if we change those, that's just improving our general health, right? It's going to improve your chances of having things like cancer, cardiac disease, heart disease, and all sorts of other health problems. Other thing I like to point out in this picture is that many factors are very related to each other. Right? So,
Hi.
Morning, how are you?
Good, how are you?
Good, you're here early.
Yeah, really early. Yeah, that's all right.
Someone needs to mute their mic, I think.
No, I'm just taking the bus.
So if you quit smoking, you lose weight and change your diet, you actually can improve your blood pressure. You can improve your cholesterol. You can improve or prevent diabetes. So making a change in one of these areas can actually affect lots of other areas, which is excellent. First, I wanted to talk about blood pressure. So blood pressure is actually the #1 risk for stroke and also one of the biggest risks for heart disease. And so I think a lot of people know the word high blood pressure, hypertension, but they don't really know what that means. And so a definition of high blood pressure is it's the force the blood is pushing against the inside of your blood vessels, particularly the arteries, which bring blood from our heart to our body, including our brain. And so the higher that pressure is, the more likely it is to cause damage to the vessels. And so many of you have probably seen blood pressure readings. There's a top number and a bottom number. The top number we call our systolic blood pressure, and that's the force when the heart is pumping. And then the bottom number, the diastolic number, is the force when the heart's relaxing and filling with blood between a heartbeat. And in general, the goal, and especially in people who've had strokes, we want the top number less than 140 and the bottom number less than 90. And this is for heart disease, stroke, and lots of other health problems. But if someone does have diabetes, this goal is actually lower. It's less than 130 on the top and 80 on the bottom. So it's important to speak with your doctor so that you know what your blood pressure target is, so that you yourself can be keeping track and understanding sort of what the goals of any treatment are. The main treatment usually for high blood pressure is medications because these act quite quickly. They can start to improve your blood pressure over a couple of days. I think a really important thing about blood pressure is we don't usually feel high blood pressure. And so I often have patients that say they stopped their medicine because they felt really well. But that actually is a problem because their blood pressure might still be high even if they're feeling well. So you don't want to stop any blood pressure pills or change them unless you talk to your doctor. Some examples of pills people might be on here are things like Ramipril or amlodipine, but there are lots of different blood pressure pills. There are a lot of other important treatments for high blood pressure. They just generally take a bit longer than medication. And some people are actually able to either reduce their medication or even get off it with some of these treatments. And we'll go through these individually, but things like improving exercise, changing your diet, losing weight. If you've been diagnosed with sleep apnea, there's a CPAP machine you wear at night that can improve blood pressure. And quitting smoking and reducing alcohol all can help to improve our blood pressure. So there's lots of different lifestyle pieces that are also important on top of medications. Another huge risk factor, the second one to talk about, is high cholesterol or lipids. And cholesterol is pretty much a fat that's found in our blood, and there's two main types that we look at. One is high density or HDL, and one is low density. And these are probably new words to people, but what you might know them as is LDL is our bad cholesterol. It actually causes fatty deposits and blocks blood vessels. And so we want this number as low as possible. And HDL is our good cholesterol. It actually helps to remove fat from the blood. And so we want that as high as possible. And so one of the major ways that we increase our bad cholesterol is through diet. And so we'll talk a little bit about some of the diet changes we can make. But in general, after someone's had a stroke, we want their bad cholesterol or LDL to be less than 2. So that's a number you can ask your doctor, you know, what does my blood test show? And ideally with medication and lifestyle, you want that less than 2. The HDL, the main way we can influence it is by exercising. Exercise brings our good cholesterol up, and also quitting smoking. Smoking brings the good cholesterol down. So just a couple terms. A lot of us talk about cholesterol that's in food. And this is usually in animal products. So red meat, chicken, dairy. And this actually doesn't affect our good and bad cholesterol as much as saturated and trans fat. Those are the fats we really want to look at when we're looking at labels, when we're doing our grocery shopping or looking at recipes. And so where do we find these things? Saturated fat is generally found in processed foods, in fatty meats like liver, bacon, things like that, in things like homogenized milk, butter, and lard. And then the trans fats are found in margarines, fried foods, many packaged crackers and cookies, and then baked products that we buy. So things like donuts, muffins, those sorts of things. So these are the kind of foods when we're looking at cholesterol and general good health that we want to be trying to limit or avoid. In terms of treatments for high cholesterol, again, there are medications that are quite effective and work fairly quickly for high cholesterol. And these are medicines you may be on like Crestor or Lipitor. And again, we don't usually feel when our cholesterol is high in our blood. And so we have to continue to take our medications as prescribed by our doctors until, you know, that you've been given any guidance on that. But again, diet and lifestyle also has a role, and long-term, some people may also be able to get off medications if they make lifestyle changes. So the first is eating a healthy, balanced diet. And the big piece for that is choosing what we call whole or minimally processed foods. So that's food you go and buy at the grocery store, and they kind of come individual, like a head of lettuce, a bushel of tomatoes, a chicken breast, things like that. Versus things that come in a bag or a carton that might have sauces and salt and things like that added. Usually by cooking at home, we're reducing how much of those saturated and trans fats we have. And so eating out really should be, I mean, now it's COVID, it's a different time, but it should be something we only do on occasion, because generally when we eat out, we eat larger portions, there's more fat, salt, and sugar. Cholesterol is also affected by weight. So having an increased body weight actually increases your bad cholesterol and lowers your good cholesterol, and reducing weight does the opposite. So just losing weight can have a big impact on cholesterol. Physical activity, I think I mentioned. So being active, again, increases the good cholesterol and decreases the bad cholesterol. And we'll talk about activity in a bit. And then smoking. So smoking significantly reduces our good cholesterol, which is, remember, protective. And actually, there's studies that show when we quit smoking or reduce smoking, those good cholesterol levels rise quite quickly, like over a short period of time. So changes do make a big difference. I think that's a good segue talking about post-stroke diet in general, which is related to the things we've talked about, blood pressure and cholesterol. So like I said, you want to have few processed foods, including sweets, sugary drinks like pop and juice or diet, or like, you know, things like Gatorade. You want to avoid processed meats. That's things like lunch meats, beef jerky, you know, sausages and things like that. And snack food as well. And in general, in the full day, only about 10% of our calories should come from sugar. So we're trying to avoid sugar. The next thing is lots of fruits and vegetables. And so the best fruits and vegetables are fresh, but you know, I appreciate sometimes for convenience, those foods go bad really quickly. And so frozen vegetables and fruit are okay, but you just want to make sure they're not adding salt or sugar, or any sweeteners into those frozen or canned products. You want them to be just the veggie or fruit themselves with only things like water added. So that's something you can look at when you're looking at frozen or canned veggies and fruits. Another part is if you're eating dairy, to try and choose fat-free or skim milk, cheese, and kind of plain yogurt are better choices for dairy. And choosing high fiber foods is really helpful. So things like whole grains, cereals like bran, seeds and nuts all have lots of fiber. And then to get our protein, we want to choose more lean meats. So that's meats like fish and chicken and white meats, and also protein from plant sources. So that's thinking things like beans, legumes, you know, peas, things like that. And these are numbers you can look at later, but the guideline is that cholesterol should be less than 200 milligrams a day in stroke patients. And so you can see that on the labels of different foods. And also sodium should be less than 2,000 milligrams in a day. And again, that's a number you can find on the labels for foods. I really like this picture. This is from the Canada Food Guide, and it just gives us a way to visualize what our plate should look like. So you can see here, 1/2 of our plate on each meal should be fruits and veggies. 1/4 should be protein sources. So that can be meat, nuts, tofu, yogurt, eggs, things like that. And then the other 1/4 is where our grains and our carbohydrates are. And so preferably those are our whole grains like quinoa, rice, whole grain bread and pasta and things like that.
Excuse me, are you showing pictures?
Mm-hmm.
I don't see any pictures on the screen. Sorry.
Has everyone else seen the pictures?
Yes, we can see it.
Okay. I'm not sure. It should be up there.
Yes.
Okay.
Do you have a suggestion for me?
Have you had a problem before?
No.
No. Do you see a video at all of people either?
Just your face now.
Okay.
Should I click on more on the top?
Yeah,
Or
maybe try
participants?
settings.
No. No. It's okay. I'll live with it. I don't want to bother you. Sorry. It's okay.
Sherry, we will be sharing the slides with you after the presentation,
Okay.
so that will allow you to still see
That's
it.
weird because it should be this is the main
Yeah.
thing. Yeah. Sorry about that, Sherry.
Okay. It's okay. Go ahead. Sorry.
And then this is just another diet that's often recommended after stroke and heart disease. It's called the Mediterranean diet. I'm not sure if people have heard of this. But you can find it online and this will be in the slideshow, but generally it's saying things like fruits and vegetables and like olive oil should be things that we eat a lot of every day. Things like fish and seafood, you know, we should choose often, at least a couple times a week. Chicken, eggs, cheese, and yogurt, we should have in moderate portions daily to weekly, and meats and sweets, we should have as little as possible. And then also indicating that when we're hydrating, when we're choosing drinks, water is really the best choice, or other unsweetened kind of drinks. So I like this visual. It just kind of shows the things we should eat more of and the things that we should be limiting. And it's still pretty tasty too, which is good. Diabetes is something that some of you may have been diagnosed with either before or after your stroke. And the main thing with diabetes is that it's influenced by all of the things we've just talked about, right? Diet, exercise, weight. And the key is that you have a goal when you have diabetes to have hemoglobin A1C of less than 7%. And that's a blood test that usually about every 3 months. And it gives sort of an average of your blood sugar control over a couple months' time. But people with diabetes, depending on if you have type 1 or type 2, will often be asked to monitor their blood sugars at least for a period of time. So you should do that as directed. You may be prescribed medications. The most common is a medication called metformin. And again, making dietary changes, exercising, and losing weight. Some people can manage pre-diabetes or early diabetes with those changes. But this is a really important thing because diabetes has a lot of negative consequences. So it can cause strokes and heart attacks, but it can also affect our eyes and our kidneys and the nerves and blood vessels that go especially to our feet and can cause like wounds and other things. So blood sugars are a super important thing to control. And I've unfortunately seen quite young patients with diabetes have strokes because they weren't really paying attention to their blood sugars. Now, smoking is another really important factor that changing can have lots of positive effects. So smoking is bad because it increases our blood pressure. Even right after a cigarette, people's blood pressure goes up. So we actually try not to take blood pressure within 30 minutes of someone having a cigarette for that reason. It also increases the development of what we call atherosclerosis. And atherosclerosis is that development of sort of fat and plaque in the blood vessels, which blocks blood flow. So smoking itself is a risk factor for blocking blood vessels without any of the other risk factors we've talked about. And finally, as we mentioned, smoking decreases our good protective cholesterol. So those are 3 good reasons to think about even just reducing smoking. And I think it's important for you to know that, you know, doctors and nurses and other healthcare providers, we appreciate that quitting smoking is hard. But there is a lot of people just think that they by themselves. But there are medications that help to reduce cravings. These are medications called Champix and Wellbutrin. And there's also nicotine replacement. So that's giving your body the nicotine it craves, but in a safe way, not with all of the other chemicals that are in cigarettes. So there's gum, there's lozenges you put on your tongue, there's inhalers, and there are patches. And in case people are interested in quitting smoking, there's actually the opportunity, at least in BC, for some free nicotine replacement for a period of time. Some pharmacies now, you can just ask and they're providing it. And you can also call 811, which is the public health number, to find out more. Or talk to your family doctor or nurse practitioner. But we kind of appreciate with smoking, there's the habit of smoking that a lot of people need to find a replacement for, you know, chewing gum, listening to music, anything else that you can find, you know, you do when you're craving the habit part. And then there's the chemical part, and that's the nicotine. And we're quite good at helping with the nicotine by using these different replacement options. So if you're struggling with smoking, either reducing or quitting smoking, please talk to your doctor. In terms of exercise, we've kind of shown in medicine these days that there is no pill better than exercise. Exercise is probably the most effective thing a person can do to improve their health. It improves your energy, it improves your sleep, it improves your thinking skills, it improves your mood, and it improves pretty much all the risk factors we've talked about so far. Blood pressure, cholesterol, diabetes, weight. But I think what the studies in exercise are showing now is that there's two parts to it. We used to just think if we exercised once a day, we were good. We now know we need to exercise, but we also need to be less sedentary. We need to spend less of our days sitting, whether that's in front of the TV or a computer, reading, anything like that. And so I think one of the keys, and I know this is a challenge in COVID for everyone, but particularly people who might have limitations for getting around, is trying to make our days more active. Things like playing with kids or grandkids, raking leaves, taking the stairs when we can, if that's an option, gardening, doing housework, all of those things are actually exercise, right? They get us a little bit sweaty and get our heart rate up. So trying to incorporate those things into our day and not just think about formal exercise, you know, things like going to the gym and stuff like that. That's important too, but there's lots of other easy ways to integrate it into our kind of day-to-day lives. The recommendations for exercise is trying to do kind of whole body exercise. So things like riding a bike, gardening, you know, housekeeping, going for a walk and, you know, moving our arms are great options. And generally this should be what we call moderate intensity. So this should get your, you know, you should be a little bit sweaty and have your heart rate up a little bit, but usually people can still do a bit of talking. They're not so out of breath that they can't, you know, maintain some conversation. I think really in the times with the COVID pandemic, walking is our best bet. It's safe, it's outdoors, it doesn't break any of the public health recommendations. And, you know, you get the psychological kind of benefits of being out and in nature. But swimming, using a stationary bicycle or a real bicycle are also really excellent options. Generally, we want to be exercising sort of 4 to 7 days a week. And the guidelines for all Canadians, all ages, is to try and get 150 or more minutes a week. So if you break that down daily, that's only about 25 minutes a day. And you actually, it will have benefits as long as you're exercising 10 minutes at a time. So if you're working on building up your fitness, you can start with a 10-minute walk and then a break, and then maybe do a 10-minute walk a little bit later and a break. It's all about slowly increasing what we can tolerate. And the exercise scientists and trainers and stuff recommend the first thing you increase is what we call frequency, how often you exercise. So if you're going for a walk, say twice a week right now, the first thing you might do is increase it to 3 days a week, and then 4 days a week after, you know, a couple weeks. The next thing we increase is how long we exercise for. So for example, if you're going for a 15-minute walk right now, you could make that a 20-minute walk. And then the final thing we increase is actually what we call the intensity of the exercise. So that's, you know, are we adding hills? Are we adding a trail so that it's maybe more uneven? If we're using a stationary bike or a treadmill, are we making the resistance a bit higher? We could add some small weights in our hands. Those are ways we can increase the intensity. So I think people get overwhelmed when they're like, I want to start exercising more. Where do I begin? Start with increasing how often you exercise. That can even be within a day. You know, I'm going to go for 2 walks today instead of 1. Then increase how long, and then increase how hard the exercise is. And I think I've been talking to quite a few of the physiotherapists here at GF Strong, and they've been seeing people with strokes who are outpatients on Zoom like this. And they've been recommending a bunch of online exercise classes as well. And I've linked all of those at the end of this presentation, so you'll have access to those. Some are videos, some are printout recommendations, and they're specifically made for people with strokes, mobility impairments. There's even one that's for patients who have tight spastic muscles. But she also says she's telling a lot of her patients to just walk and to try and do things like gardening, because gardening is a whole body workout. And sometimes gardening needs to be modified. So, you know, putting our plants maybe on a table where we can sit and work, things like that, depending on what our limitations might be. And then this kind of guides us to weight. And I think weight is another thing that's really overwhelming when we think, I want to lose weight, where do I begin? But I think it's really motivating to know that even losing just 5 to 10% of your weight actually can significantly reduce your blood pressure and decrease your stroke risk. So that's a pretty small amount. And so if you think about doing that, you know, in small little steps, there's a benefit to each improvement. And so, you know, when you need a little bit of motivation, sometimes it's better to take things step by step and to achieve little goals rather than thinking, you know, I want to lose 20 pounds or something that's a really overwhelming weight and goal to think about. So these are just some numbers we use in medicine. I don't know if people have heard of body mass index or BMI, but this is really how we compare our weight to our height. So it doesn't make any sense to look at the weight of someone who's 5 feet and compare it to the weight of someone who's 6'5". Obviously, you expect them to have different weights. And so we use this to compare our height to our weight. And a normal BMI is 18.5 to 24.9. And so if it's more 25 or more, you're overweight. And if it's usually 30 or more is the obese category. And so this is something you could ask your doctor to weigh and measure your height and to do the calculation for you, and something you can keep track of. Because just weight by itself isn't that useful. It kind of needs to be compared. Also, sometimes measuring our waist. Our waist is the smallest part above our hips. There are guidelines that women should have a waist circumference less than 88 centimeters and men less than 102 centimeters. And those are, meeting those cutoffs is a predictor of decreased risk of stroke and heart disease and other things. And like I said, you know, you want to set healthy weight loss goals too. It's not healthy to lose lots of weight. And you also want to do it in a way that's specific for you, so that what works for one person might not work for someone else. And you also want it to be something you can maintain. So, you know, a lot of people will lose a bunch of weight and then the way they were losing weight was not maintainable. It didn't fit with their lifestyle. And so you have to think about things that you can change slowly and that you can keep up for periods of time. So this is where you can kind of start with small changes. And on one of the websites I've linked, the Heart and Stroke Foundation, they actually have a little book where they have people set what they call action plans. And I know our occupational therapists here at GF really like action plans, which is essentially where you set a very specific goal. So you're something like, I'm going to walk for 20 minutes, 3 days a week. And then you keep track of that. And then you set another specific goal. But they have to be specific, or else, you know, if you just say, I'm going to exercise more, it's hard to measure if you're doing that. And then I just wanted to talk about common medications people are on after stroke. So we do talk about 2 types of stroke. The most common type is what we call an ischemic stroke. And that's where there's been a clot that's reduced blood flow to a part of our brain. There are people, though, who also have had what we call hemorrhagic strokes. That's a bleed that's caused damage to the brain. So in patients and stroke survivors who've had the clot type, the decreased oxygen to the brain, almost always they'll be put on a baby aspirin. So it's usually 80 or 81 milligrams, and that's generally for life. And there's very good scientific studies that show that this reduces the risk of stroke and mini stroke and heart attack by quite a lot. So that's a medicine you never want to stop without talking to your doctor first. Some people on top of that will also be put on another pill called Plavix or clopidogrel, sometimes with aspirin, and that's usually for a shorter period of time, anywhere from a couple weeks to a couple months. And essentially these medicines, they're not blood thinners, but they prevent our blood from being sticky. They affect our platelets. Our platelets are little cells that are moving in the blood with our oxygen-carrying cells and our infection-fighting cells. And when there's a damage to the blood vessel wall, they kind of create a clot. And so we're trying to prevent that from happening with that medication. Some patients after stroke, if they have atrial fibrillation or other clots, may be put on a blood thinner. And then the other main meds people are put on are blood pressure medicines, cholesterol medicines, and diabetes medicines if they have these problems. So I'm sure most of you are on at least one or a combination of these medications, and these are an important part of your preventing having a stroke. So really important. I just have this little section. I'm not sure how are we doing for time. I might leave these for you to look at on your own so we have time for questions, but I kind of broke down what's your doctor or your nurse practitioner's job and what's your job. And I'll maybe just skip ahead to patients' jobs. In my opinion, your number one job is asking questions and understanding your health. So I have lots of patients that kind of go, you're the doctor, whatever you say. But there's studies that show people who understand their health do better, right? And so doing things like asking why I'm on this medicine, what's the point of this medicine, knowing your numbers, so knowing your blood pressures, knowing what your blood sugars are, your cholesterol numbers, and knowing your medicines. That doesn't mean you have to memorize them, but maybe having a list, keeping them in a notebook or on your phone, and having written next to them, you know, this one's for blood pressure, this one's for cholesterol. And my patients here at GF, I actually give them a handout during one of our first meetings that goes through their risk factors and what we're doing about each of them. And I think another important piece is staying in touch with your healthcare team. And if you have any questions or concerns, is booking an appointment. Some people will also be asked to monitor their blood pressure. And one of the links in the end of the presentation has a really nice little card where you can put your readings in so that you can bring them to your doctor. And these are just some things you can look at later, just recommendations on how to keep track of your medicine, because I know it can be pretty overwhelming. Things like getting blister packs or buying one of those days of the week pill containers. Getting your pharmacist to print out a list can be really helpful. Having reminders on your phone or alarm clock or whatever you like to use to tell you when to take your medicines, little things like that. And then I think the final piece that's really in patient's control that, you know, doctors and nurses can only recommend and help guide is lifestyle changes. And there are ways to get some help with things like exercise, if you have the ability to pay or have some benefits, things like getting a trainer or a kinesiologist or seeing a physio, seeing a nutritionist or dietitian, seeing a counselor, nurses, and then using your friends and family, trying to make changes maybe with your spouse or with your kids. You know, we're all going to start exercising more. We're all going to change our diet. I think can really help make it, you're accountable, right? You have other people that you need to kind of support and make change for. So I find that that's usually one of the things that helps people the most.